Hi guys, it's Dr. Nyla, and welcome to week number 4. This module is pretty extensive. It covers neurological all the way over to mental health. So I definitely advise you to set aside some extra study time just because there's so much information that has to be covered. So in addition to this mini lecture, I will also provide you guys with supplemental information, which is available in your course announcements.
The first topic that we'll cover is vertigo. Guys, never miss an opportunity for a good meme. I love memes, so I chose this one. When you encounter patients with vertigo, I promise you this is exactly how the conversations with these patients go. If you've ever had vertigo, this is exactly how you feel. I've had vertigo and I felt just like the person in this meme. So, when a patient presents with vertigo, just know that vertigo is actually a symptom of an underlying condition. So, patients may talk about having vertigo, they may describe presyncope or actually experience a syncopal episode, and there will also be something that sounds like they are experiencing periods of disequilibrium.
A very important point about vertigo is that vertigo is a symptom. Remember that. Vertigo is a symptom. Vertigo is the result of damage or dysfunction to the labyrinth, vestibular nerve, or central vestibular structures in the brainstem or cerebellum. Again, vertigo is a symptom. Patients will experience presyncope, some will experience syncope, disequilibrium, and nonspecific lightheadedness. So if you're experiencing those symptoms, you will feel like the person in my previous meme. Clearly, I love this meme, but seriously, vertigo is a symptom. And this is how your patient interview is going to go. And if you ever experience vertigo, this is exactly how you will feel. But it's a symptom of something else going on within your body. And I'm also using the term vertigo lightly. Symptoms such as vertigo, dizziness, lightheadedness, I'm using them pretty interchangeably in this conversation, but they can be definitely different and different for documentation purposes, okay? For patients that are experiencing lightheadedness or syncope, the most common cause is cardiac. Extremely important that you remember that. So with patients that come in with unexplained lightheadedness, presyncopal episodes, syncope even, don't forget that cardiac workup. Less common reasons for syncope or near syncope or vertigo are hypoglycemia, seizures, and it is very rare that this is a symptom of an impending stroke, but it should still be on your differential list. Other things to add to that differential list can be vision impairment, impaired cerebellar function, or some involvement of motor centers such as the frontal or basal ganglia. Additionally, please recognize the clinical features of vertigo. Know what diagnostic tests can be performed during your physical exam. So think of your Weber and your Rene testing. Physical exam findings. You may find some nystagmus, and those images are different types of nystagmus that may be present upon a physical exam. We're fresh out of physical assessment, so don't forget about those Hall-Pike-Dix maneuvers. Know when to refer and know how to treat this. Remember, we're looking for an underlying cause, and it is always important to always be preparing a differential list. Now we will move on to headaches. Please focus on these common types of headaches: tension, migraine, and cluster. Notice the star here. This is very important learning information. You are able to pause the slide here if you would like to take a quick look at this slide. I also believe that I have included this in your weekly announcement. Red flags and headaches are extremely important. I want you guys to commit these to memory. Be prepared to be drilled on these in your clinical practice. Be prepared to see this on examinations and on your board exams. Red flags and headaches are things that you absolutely have to know. One of the big red flags that you better never, ever, ever, ever miss is if a patient tells you that they are experiencing their worst lifetime headache, This is something that has to go to the emergency room and should not be evaluated in your office or taken lightly under any circumstances. That's a red flag that should not be overlooked. Additional red flags are listed here. If a patient comes in with a headache after the age of 50 and they've never had headaches before, that is a huge red flag. Thunderclap headaches are red flags. Patients that are experiencing neurological symptoms should also be sent to a higher level for a workup. And if their headache pattern suddenly changes, that can be an additional red flag. Symptoms of meningitis should not be overlooked. If the patient begins to experience red flashing lights or halos, those are also things that should never be overlooked, along with symptoms of giant cell arteritis. The management of migraines is something that you will encounter frequently in clinical practice. So please start developing your treatment plan for migraines. For these patients, teach them about triggers. So for some people, fermented cheese, for instance, may be a trigger, or red wine could be a trigger for some people. Lack of sleep could also be a trigger. So make sure you are very well versed in potential triggers for migraines. Also, look at behavioral changes for migraines. Again, things such as lack of sleep could be a trigger for people, and telling them just to get a little extra shut-eye could be a way to improve their migraines. Know the difference between abortive and preventative therapy. Be sure that you have an awareness of the different types of migraine medications and be prepared to be tested on those, and also know the dosing. And when you have a patient with migraines, make sure that you treat their symptoms. For instance, migraines can often be accompanied by things such as nausea, so please administer a medicine for nausea. And also, always do a complete H&P on these patients, and be sure that you perform and document a complete neuro exam. I know that I just said this, but it is important to know those medications. So commit that to memory. Know your red flags, know when it is time to refer, and always, with every condition that you treat, you should be prepared to at least outline 3 potential differentials for whatever it is that you are treating. We'll move on to trigeminal neuralgia. Trigeminal neuralgia is a pain disorder, and it affects the branches of the trigeminal nerve. Patients will describe this pain as sharp or stabbing. It is usually unilateral, which is a very important distinguishing factor. Advanced imaging is not always recommended for these patients. It's not typically needed, but sometimes you will do some testing as a way to rule out other potential causes for the pain. The diagnosis of trigeminal neuralgia is typically going to be a clinical finding. So this means that your diagnosis will be based on your history and your exam. The cause can be primary or secondary, but as a clinician, you will work through this during your H&P. And now it's time to treat the condition. So again, you have to have a medication plan ready. Always have several different treatment options in your arsenal. Know the stepwise approach to treating most conditions. And in this case, there is a first and second line. You should know when to refer, and definitely do not abruptly discontinue these medications. This brings us to the end of a very quick overview of trigeminal neuralgia, headaches and migraines, and my favorite, vertigo. Never miss an opportunity to use a good meme. That's it. Let me know if you have questions. You guys know how to reach me. Take care.